Okay, we're going to go ahead and call the meeting to order, and we're going to recognize we had a quorum, just Jan missing. All other board members are present, so we're good there. Item number 3 on the agenda, did everybody have a chance to look at A through D? And were there any questions, comments, or concerns with any of those?
No. I'll make a motion to approve.
I have a first, can I get a second?
Second.
And Mike, with that discussion, just real quick on the credentialing, we're happy to say from the Personnel Committee that 3 of our providers met exemplary practice criteria this time as we're approving the credentialing.
Thanks.
So Scott Markham, Sarah Devine, and Jill Ferry were all at that level of meeting exemplary practice criteria. So congratulations and appreciate their work.
Awesome. Thanks, Terry, for that. We do have a first and a second. All in favor?
Aye.
Opposed? Same sign. Motion carries. Mid-staff meeting by Chief of Staff, Dr. Devine.
All right, we had 2 of them, so we'll go through July 1st. We had the quality improvement reports for all of the departments, and then had to go through and make sure that we had no issues and it was good. Nicole reported that DIA had been out and reviewed charts and found no problems. Nicole revealed the Sentinel node imaging policy revisions. Basically, that's about if you have a cancer, you want the first node up to be biopsied as well. And we just reviewed the policy and updated it. Dr. Sekundiak from MD West Wong would be starting to see patients in July. He's already seen 1 clinic now. He's an orthopedic that does hip and knee joints. He was in Omaha and then moved to North Dakota and now he's back. So, Jennifer Brook took first assist training and can close surgicals now for surgery. It was 130 hours of completion for training. We are evaluating equipment for an in-house MRI. That project will be pushed back to 2026 as we have so much going on with the building right now. In July, there were no credentialing applications, and we had 2 new staff hired for the informatics department that started that second week in July. Then we came to the August one, which was this morning. We discussed that we have some remote pharmacists available via Tiger Connect for night times if we have any questions on pharmacy. There is a nationwide Bicillin shortage. We went through the credentialing and that we discussed those. There were no concerns on any of those. And Epic issues and updates, we're going to have an upgrade on October 4th, and they're expecting that to be a fairly big upgrade, so I'll start learning again. And that would conclude it.
Okay. Thank you, Dr. Devine. We'll go to the quality improvement report by Laura.
Okay, we had our last system-wide QI meeting on July 16th, and we had 16 departments report at that, so I'll just go over a few of the highlights. Behavioral health has a new measure that they've been working on for monitoring intake assessment and kind of reduction of their no-show rate. They really want to optimize their time and reach as many patients as possible. Cardiac rehab evaluated 6-minute walk test and had 100% of patients showed improvement. For the dietary department, Catherine's doing a really great job of developing some new monitors and efficiency with inpatient consults completed within 24 hours. Medical records monitored the completeness of documentation for ED records and OB provider coding. Infection prevention reported that there was no health care associated infections. Rehab services is monitoring the fall rates for PT, physical therapy, occupational therapy, and speech therapy, and then have a goal to partner with the ER for any patients that come in post-fall to be able to reach those patients as well. Utilization review reported 100% compliance with sepsis standard of care for all of those patients. And we really look at readmission rates really closely as well and how we can kind of curve that a little bit for any patients that are readmitted to our hospital or even another hospital within 30 days and how to
Does that
best
go
prevent
against-
that.
Does it go against you then? Like if they were to come here and get service and then they went to the city?
Correct, yeah. We look at, it's any hospital, or same hospital, so readmission to the same hospital or readmission to any hospital. Yep,
gotcha.
yep. So, yes, and that's all I have.
Great, thank you, Laura. Administrative reports, we had Chief Nursing Officer Nicole Hinger, but she's deferred. We'll start with Chief Clinic Administrator Kim Burchett.
Perfect. So construction is progressing nicely, the new building. Today we actually did tours with all of the behavioral health staff. So they were able to see their space and kind of see where we're at. There's pretty much final paint on the walls upstairs in the behavioral health side. And then some of the casework is going in. They do have done within the restrooms, which looks really, really nice. So kind of nice and exciting. They're all pretty excited and nice to see where they're going to land. Next week, we're hoping to do the walkthrough with the clinic side of staff, being providers and then nursing staff. That I would extend it to you guys, that I can let Ruth know once those are scheduled. If you guys are interested, just reach back out to Ruth and we can get you coming through at the same time.
Yeah, that'd be good.
Thank you.
All right. Thanks, Kim. Chief Human Resource Officer Jill.
Yep. So we do continue our recruitment efforts for OBGYN. We are targeting specifically practicing physicians and 2026 grads and really looking for those individuals with ties to Iowa and surrounding states because they're more likely to retain them here. So that's our update on OBGYN recruitment. We also measure staff retention year over year. So I wanted to share with the board that we had 88.6% retention rate at the end of our fiscal year. So that's really positive. Our goal as an organization is 86%. So above goal, and then we also look at specific departments within that to make sure, like our nursing staff, we're seeing nice year-over-year increases in retention at 90%. So that's important to us in order to continue to serve. The last item I just wanted to share with the board, Myrtue was awarded a 4-star excellence award for inpatient services from PRC. PRC is the company that we work with to survey inpatients on floor and in OB. That's a CMS requirement as well. And so we rate in the top 25% nationally for overall quality of care. And that was for 2024. That data just came out here in this last few months.
Awesome. Thank you, Jill. Next, Chief Information Officer Jeff.
All right, we'll start out kind of backing up what Kim had said about the construction. There's actually quite a bit more going on a little bit. The final paint is on the second floor, but the first floor painting has started also. So it's fun to see that it started to come to a finish. Second floor, they will start putting ceiling pads in. The grid's there, but now they'll start putting pads, and then they'll start also, they're prepared to start laying flooring on the second floor. You'll see as you look through into the reception registration area on the current clinic, there are ICRA, or the infection control walls, that are up, so they've started to migrate into the existing space to get that updated and prepped. Outside, you'll see a big backhoe going. That is for a rainwater retainage system. So as the rain hits this, before we had all green space, the ground would absorb the water. Now that it's all building, it has to go someplace. So that retainage system is a bunch of pipes underneath the ground plus a couple containment that limits the outflow or controls the outflow into the storm sewer instead of all hitting it at once. Landscape is set to start on September 10th, so that'll be kind of nice. That will also be after the parking lot has been poured, so that some concrete work will be going on in the next couple weeks. And also the elevator work has been started in that northeast corner. So lots of great movement in the rural health clinic. On the inpatient side, All the final paint's been put on the rooms there, and flooring is set to start on Monday. So we're hoping in a matter of a couple weeks, we'll have that wing open, ready to go again. And then we're working through how to accommodate the new nursing station, because it will potentially lock off or put the northwest wing unavailable for a short period of time. So we're working through some timing there. Dr. Jonk has moved into the old ED area and has been practicing out of there for a couple weeks, and haven't heard anything, any issues, so things appear to be going pretty well there. IT, the PCs, we're adding like 70 to 75 PCs to our fleet for the rural health, so we're starting to get those ordered and be working on those and ready to place when that's ready. Epic side, an upgrade is coming on October 4th overnight, and so we started script testing yesterday, which is there's I think 11 or 12 scenarios that we go from a patient presenting at the front door to billing, and test everything in between there on the upgrade that's going on. So far it sounds like it's been going pretty well. And on the EVS side, knock on wood, as of Tuesday last week, we are full staffed with full-time positions. So that's pretty exciting. It's been a few years since we've been full staffed there, but the team has been very cohesive. I mean, they've come together and they work very well together. So it's a really good group of people.
Would you say that the construction phases are meeting the timelines that are expected?
On the rural health clinic, the new construction, yes, it is appears to be on time. We did run into some flooring issues on the inpatient side that it's supposed to arrive here on Thursday. Originally it was supposed to be in early June. So the flooring has been an issue there. We did have a plan that we had, Myrtue had a supply of 3,000 square feet. We were going to let the construction company use that and then backfill our order, but they haven't started laying the floor yet, and so ultimately with the new floor coming, they'll just use out of that stock. But other than that, we have been able to accommodate, with a census that's been reasonable, not outrageous, we have been able to accommodate all our patients. Any other questions? Thank you.
Yeah, thanks, Jeff. CEO Barry's next.
So I wanted to talk to you a little bit about the ortho group that's coming out, MD West 1. So Dr. Devine did mention that Dr. Sekundiak has started, and he looks like he's going to be pretty busy. He's come out, I think, I think he's been out at least 2 or 3 times. And then Dr. Turman is a sports ortho. She'll be starting January 1, and then Dr. Shutt is a foot and ankle as well as trauma. So he should be, we thought we could maybe get him started in November, but with some holidays, I think it's going to be difficult scheduling him until January as well. So we should be in a really good position moving forward, having Dr. Hsu as our hand surgeon, and then the MD West 1 orthopedic group coming out should be in a good situation moving forward. I did want to it's been a little while since we talked about the ACO, our Medicare Accountable Care Organization, and I'll maybe just give you a high-level update on that, and then Laura's going to talk a little bit about some of the actual work detail work that we're doing to meet some of those measures and do a good job with care coordination. But for 2024, we are still waiting for our results. It usually comes out in August. We think it's probably going to be in September of this year. So the results of whether we had shared savings or not. So we'll get that here really soon. One of the main strategies this year is the annual wellness visits. So the idea there is if we're doing a good job with getting those Medicare patients in for annual wellness visits, we reduce the likelihood of them showing up in the ER or having to be admitted as an inpatient, and that's where a lot of the big costs come from. And at the same time, we're doing a good job with the care that we're providing and preventative services as well. So it's both good on the finance side and on the care coordination side. And we did have about a 20% increase in annual wellness visits this past, in 2024 from the previous year. So doing well in 2024, and we'll know, like I said, here in September, whether we had any shared savings. In 2025, we just only have claims in through March, so we really can't really estimate how well we will do in March or for 2025 at this point. And for 2026, we did sign a contract to move forward with into another year of accountable care work. They're going to move us into a different ACO. They do an actuarial analysis each year to show which ACO fits us the best and which one will allow us most likely to have shared savings moving forward. And I think we talked about the name change to Wellvana for this next year. So that's just a little bit of information on the ACO. Laura, do you want to talk about some of the work we're doing on the care plans?
Yeah, I can just kind of give you an overview of what the measures or certain quality measures that go into the ACO that we follow and monitor. We monitor them really closely on a monthly basis, but those measures are a depression screening, and if that screening is positive, we have an appropriate follow-up. The A1C, tracking the A1C numbers for our diabetic patients, breast cancer screening, colon cancer screening, tobacco use screening, and cessation education if that's positive. Screening all our patients for fall risks, hypertension management, and then reviewing their medications at a really thorough basis. As Barry had kind of mentioned, this is a Medicare ACO, but we feel really strongly about doing this for all patients, all payers across the board. So any patient that comes in can expect to receive this education, or that we're addressing it on some level, whether it's at fall risk screening, tobacco cessation, depression screening. So it's really a focus on best practice, that like for the breast cancer screening, that patients are getting that mammogram if they're within that certain age group, and that we're hitting that mark. It really keeps it at the forefront by looking at those measures on a monthly basis. It's well communicated between the medical staff, the rural health clinic, and then the senior admin team as well. Barry also talked a little bit about the annual wellness visits. That falls into the ACO as well, and a focus on prevention. And then chronic care management is another like spoke in that wheel. So if a patient has heart failure or Parkinson's disease or something like that, that we're connecting with that patient a certain number of times throughout the year to prevent those readmissions and ER visits. So it's really a great program. It takes a ton of hands to make this come together, but it's going quite well. So.
Do we follow up on a local level, like, so they're not a Medicaid or Medicare patient, and we're doing it across the board with all patients? Do we follow that through then and reward our physicians that are following those?
It's all patients, all paid.
Are we as a group, though, keeping track of those measures and seeing if who's hitting them and who's not hitting them?
That's correct.
Okay,
Yep.
and then that gets reported to the
providers
Okay.
at a provider level.
Gotcha.
Yeah, through the rural health clinic.
Okay.
Anyway, yeah.
Do we incentivize them at all through our group?
Yeah,
For that?
we do. I mean, the doctors and the nurses in the clinic, so they are incentivized for that work.
Gotcha. When it's not a Medicaid or Medicare customer, right? Right? That's where.
This
When
is
it's
a
outside of the
Medicare.
ACO.
What's that?
We're following up with the AC, not like, it's not an ACO measure, but it's like, we're following up with our regular patients. That's getting incentivized also?
I think we're looking at all patients when we do
Yeah,
that.
Okay.
but just from
analysis.
those ACO measures.
Okay. Gotcha.
Does that answer the question?
It does,
Okay,
yeah. I just want to make sure, like, that if there's people that we're getting, and like, you have one physician that's handling it all, doing 100%.
Oh, sure.
And there's other people that aren't doing it for the people that are not Medicare customers, or, that don't follow the ACO, that it's over the whole level.
Yes, it is over the whole level.
That's
Yeah.
So is it up to the patient to schedule their wellness visit?
Kim could talk to that a little bit more too, but they reach out to those patients, the health coaches through the rural health clinic, reach out and connect with those patients before scheduling. They kind of do a lot of the back work on that, and then they come in and see
I
the
don't
provider.
understand those patients, what's that?
Medicare patients. So the Medicare folks, the Medicare folks are the ones that can qualify for the Medicare annual wellness that Gary's specifically talking about with
Okay.
this.
So-
But, go ahead.
I'm not being reached out to, so I'm wondering.
Got you. Well, it's a combination of everything. So patients can call in, they can request that, which we do have. The nursing staff, so if they're seeing people in the pod and they're recognizing that they are not having a Medicare annual wellness visit yet, they will refer them to the health coach, either through the provider or through the nurse.
Okay.
And then the other way, as what Laura said,
Right.
the health coaches can reach out to them. We have just shy of like 3,000 Medicare folks that we are needing to do the Medicare annual wellness visits for. So just as Barry talked with the percentage, that's what we're trying
Okay.
to climb higher on. So you might be just one of those folks that we haven't gotten to just yet. But we're trying to
I've had
go
one
on.
19-point check or whatever, but that's been a while, so.
This is the it's really not.
Yeah, my tires.
But
Well,
we certainly encourage anybody that has it, that may be in that Medicare age group, if they have not had one, to contact and call
Yeah,
into the clinic
I
and
need
schedule, or the
to.
health
It's just
coaches.
really easy not to.
Right. They do a big push for those that are just turning that 65 to get
Right.
their welcome to Medicare
Right.
physical.
Yep,
So,
okay.
What do you call it, centralized scheduling, or the clinic could get this done, right?
absolutely, you can call either, you can request to talk to a health coach or to the main number.
Or from my chart as well,
Oh, yeah.
reach out to the provider.
I will. Maybe.
That's all.
We're all here to help.
Yeah.
We will follow up with.
I'll get right on it.
Succeed. We're all going to college.
We'll call for you.
I do have just a couple other things I want to go over. So I know we're in the middle of this large project, but we do think about the future even now. So we're seeing some growth in the OB and OR area. So we have done some planning and just trying to figure out what we might need down the road, and just for future consideration. So we did have an outside consultant, kind of in coordination with our architect, look at the current and future anticipated needs for those two areas. With the OB, we're trying to grow that department. We've talked about that a lot with Dr. Kelly Anderson's outreach that we're working on now. But in order to make that and keep it financially sustainable, it's really about the volumes and the number of deliveries. We've seen quite an increase in the last probably 4 years. I think we were down to 52 deliveries 4 or 5 years ago, and this last year was 100 deliveries. So we've seen some growth. We're doing the Manning outreach. We're going to do Audubon. We'll talk about Denison down the road for OBGYN outreach. Obviously, we're recruiting for a second OBGYN. So we've looked at the OB facility that we have now. So part of that analysis is looking at the demographics and what could we potentially see for growth down the road. Obviously, Denison's no longer doing OB. We've got some other hospitals around us that aren't doing OB anymore. So there is potential for some growth there. So they go through that process and look at the demographics and what our potential future growth could be. But we also look at the facility that we have now and what we can accommodate there. And that's more through the architects. And what they showed on this analysis was that if we went to 150 deliveries from where we're at now, we would need one more, a fourth LDRP room. And if we got up to as many as 200, we'd need another LDRP room. But what's good about that area up there, that third floor, is we do have quite a bit of room to expand without doing an addition or anything like that. We have quite a bit of office space up there that we could move those individuals to somewhere else to be able to expand our OB footprint. So that's just something to consider for the future. On the OR side, kind of thinking about whether we have 2 OR suites right now. Do we need a third? I think that was kind of the thought process. We also know that currently we don't have enough storage for OR. So it was kind of looking to the future, but also more urgent needs as well. The same consultant looked at that. Kind of kept it fairly high level. But what we really wanted to show was that we could add a third OR suite and not impact the work that we're currently doing on the specialty clinic. We don't want to do that work and then come back a few years later and tear back into that area. So, and they showed that it is possible for us to add that third OR suite 3 years, 5 years, whatever, down the road if we need it, without kind of impeding in on the specialty clinic square footage. I mean, it would require us to go north, but we wanted to go through that exercise to make sure that that was possible, and we believe that we are in a position where we could do that. So those are just some things that we've been working on, just considerations for the future. And the storage issue for OR, we did come up with some good solutions there as well that would go along with the specialty clinic work that we're doing, that we're going to be doing here in the next few months. So there's some good solutions for that as well. I think those were my main things that I wanted to cover today. Any questions for me? All right.
All right, next we'll have Nancy, Director of Pharmacy. She wants to talk about a capital purchase request.
Okay, before I get going on the proposal, first of all, I'm Nancy, I'm Director of Pharmacy here. I want to just give a little simple explanation as to why we would want to add these 3 extra on the cells. As director, safety is really my #1 priority for patients. If you're going to have an error, a lot of times that will be with medication. I'm sure many of you have read about that in the news. They have it in there, lawsuits, things like that. The other thing is processes that make it easier for staff to not have those events, and efficiency to make them successful, that it doesn't reach the patient. That's really our top priority, and Omnicells help us do that. In the state of Iowa, like if we're not here, we're not a 24-hour pharmacy, so we will have an in-house supervisor dispense, and it's a gray area, and we don't like them to do that, and Omnicells help us prevent that from happening in our overnight shift, and it makes it a much safer thing. Also with like state, federal, CMS guidelines and regulations, you have to have your medication and narcotics locked up in a system where it can be tracked. That system is also connected to Epic, which is our CPOE, and so it attaches that order when that provider puts it in the system to that automatic dispensing machine and matches that up and allows the nurses at bedside to scan that. So you're much less likely to have an error. You know that those NDCs with those medications are lining up. So we've kind of changed here at Myrtue. I've been here for 13 years. We used to really focus on skilled patients and inpatients and in that direction. We've kind of transitioned into other areas with specialties coming in. So like with our OB unit, we have that, and we've increased our numbers. And in our endoscopy suite, we do have that specialty, but that Omnicell will also be used for other specialties that are coming into the surgery department. And then our rural health clinic, our overnight clinic, all of these medications that don't have an Omnicell are being done manually. So it's a process. And so In the pharmacy department, I have 2 technicians, and they manually track all that stuff. And it becomes hairy, you know. We do have a good system. We did not get dinged or anything, or have gotten a deficiency. They're very organized, but it's a stressful situation, and I don't want it to lead to an error. So, you know, you kind of look at what could become an error, you know. So you want to prevent that before it actually happens, and that's kind of where we're at here. So with OB increasing, our surgery department with different specialties, and honestly, our rural health clinic at night is very busy. So we replace those meds all the time, but we have to track them in and out because of federal regulations. And so that's just one person doing that, and this will all help that be automatic. So we won't be spending all that time. We can focus on other things that are important. So, anyway, at that being said, that's why, going forward, why these Omnicells are very important. So it's the safety and reduce hospital liability, to propose the implementation of automatic dispensing machines, which is Omnicell is our system. I will tell you, I've worked with Omnicell for quite a while. I have worked with Pyxis. Omnicell is a great system. It's durable, it does not break down. We don't really have a lot of problems with them when they have to come out and fix them, which is very rarely. So at that being said, that's pretty good, because you got nurses in and out of there slamming those doors, you know, just because they're in and out. You know, they're busy, so they do get a lot of action, so they are a good machine. So we would like to add them to the OB unit, the endoscopy suite, the rural health clinic. These machines will ensure full compliance with state and federal regulations, but they will also be in compliance with CMS guidelines, which is way more stringent. For medication security and tracking, this will include all medications. So like that's class 1 through class 6, class 2 through 5, they have to be in a double lock system, and those Omnicells provide that for that. We can transition from a manual method to a streamlined, trackable system, improving medication handling, minimizing errors, and strengthening our internal monitoring and auditing capabilities. So we do have Omnicells, like I said already. We have a very large one in the inpatient unit. We have a really large one in the emergency department. Operating suites, we have anesthesia stations in each OR suite. And we have a small one in PACU. The PACU one, all 3 of the new ones that we're going to add will be the PACU size. And these are the areas which I just said that we are proposing to add to. For quality, I mean, we have a ton of quality in pharmacy, to be honest. We just had an audit in May. We had 30 categories that we had to meet, and they cover many areas. So pharmacy is very much about quality. So like I said, we'll meet state and federal requirements, double lock systems, traceable systems, error reduction. Diversion is a big thing now. We have to prove that we're doing something about diversion now. It used to be where they would come in, and as long as you had your perpetuatory inventory, okay, that was fine. But now we have to actually prove that we are monitoring that stuff up on the floor. And Omnicell allows us to print a lot of reports out of it to track that. And so that helps us meet those state laws and CMS guidelines. A lot of people have went to AI systems. They're super expensive. We're small, so like this helps us not have to purchase that AI system, and we still meet those requirements by getting those reports out of there. Medication handling support. I mean, we handle a ton of different things here. Our outpatient clinic, like I said, all those specialties that come in here, those drugs are changing every month. So like, it's just really changed in the pharmaceutical world. Inventory management. We are required to do outdates every month, and we are required every day to do cycle counts of all narcotics in our building. So Omnicell helps us in a much easier way be able to track and do that. Otherwise, doing it manually is very difficult. It helps us tracks staff behavior, and that's actually part of that diversion monitoring. Like, it helps us see what certain, if two nurses are witnessing each other, or just behavior overall, we have to prove that we are watching all that stuff. Legal protection, it's by far, you have to be able to track drugs from the minute they reach your facility to when they leave. And that is a new federal law. It's actually been around for a while, but they're now going to enforce that in November of this year. And so we have to be able to track that drug from the moment it comes in here to every place that it's been within our facility, and if it goes outside of our facility. Services, increase patient safety, and honestly, that's our number one. It's always going to be our number one. Liability reduction. It diminishes the hospital's risk of exposure through more secure medication handling. Like I said, our compliance reporting, we do get all those reports out of there, and we do monitor those daily. Efficient restocking. Omnicells are really easy at the bedside. You put your finger on it, you scan the drug out, you take it to the bedside and you scan it. It's the maintenance on the back end that is very difficult. So we really need to simplify that for our staff. And just evolving standards. Manual processes are no longer acceptable. We didn't get no deficiencies on it. They did want improvement there. So, especially in OB, because we're seeing so many more OB patients, and when OB patients go home, sometimes they do get narcotics. My concern is if, you get more high-risk patients with OB, the more you get, and I want to make sure that those drugs, maybe like for a bleed or something, are always stocked up, and if you're doing it manually, there's always that opportunity to maybe not have that done. So human error, it will always be. When you get more of an automatic system, you lessen that. Modernization, honestly, Omnicells are not new. They were around 30 years ago. We just didn't need it at the time. Our facility has changed, the type of patients we're getting has changed, the medication has changed. So, we just have really evolved in a different direction. So that's why we are needing it at this time. Some of this is duplication, but like improvement of staff satisfaction. Also, staff burnout. That's a thing, when you're overseeing multiple departments manually, so it will really help with that workflow. Minimizing time spent, audit-ready reporting, and we did talk about that before. Error prevention, enhanced oversight, and that's that diversion thing, and that's your state law, but it's federal law, and it's also CMS law, or CMS guidelines. And when it comes down to that, we have to go with whichever. If state law is more stringent, you go with state. If federal is more stringent, you go with federal. If CMS guidelines are more stringent, then you go with that. So whatever is most stringent, that is what we have to follow. So finances, I will tell you, I will give a little bit of a shout out to Omnicell. They have actually been, on the clinical side, pretty good to work with. They agreed to do a corporate contract with us because we hold more than one IP in our facility. They allowed us to do a corporate contract at this time with them, which actually knocked off about $130,000 off of this cost. So I thought that was pretty good. This is for the grand total for those 3 Omnicells will be that price. And we do always carry a support service agreement. And this is what the $10,440 was what it is this year. It goes up a little bit every year, maybe like 2 to 3%, I think, in the last couple years. And that's just, they will come out and service your Omnicells whenever something goes wrong. And we have to have that because going without them, it would take a lot of people to run meds all over. So, and they're very good. One thing I will say about Omnicell, they're good about their support. Pyxis, I've talked to other hospitals, I've worked with them at Children's. they're not as good about coming out. So Omnicell's always really done a good job with that. Future annual support services, like I said, and that would be next fiscal year, that 10,440 probably go up about 2 to 3%. And
But not anymore for the extra units.
right.
It's all covered
Yep,
into
the rest of the year, they're all included in that 10,000, and then next year on our new contract, which is around this time of year, it'll probably go up a little bit. So, at that being said, we strongly recommend the purchase and installation of Omnicell systems in the obstetrics unit, endoscopy suite, and Harlan Rural Health Clinic. Current reliance on manual processes in these areas introduces unnecessary risk and inefficiency. Human error is inevitable, and manual tracking places excessive demands on staff, increasing the likelihood of mistakes, potential regulatory noncompliance. Implementing Omnicell systems will not only reduce these risks, but also improve medication safety, staff efficiency, and compliance with legal standards, ultimately supporting better patient care. So, any questions?
Do you manually fill these then?
Yes.
How often do you do that?
Every day.
Like a bulk
Twice.
fill? Okay.
Twice a day, yep.
So you take
So-
that unit back to your unit?
Yep. We don't take the unit, they stay up on the floor, and then we haul it up there on carts.
Okay.
So we get reports, a report will print out, and the girls know. It'll tell them their par level, how much they've used. So like when they come in the morning, it gets a report that prints out, and then it tracks that, and they know what to fill. So like manually, you would have to go up there, yeah.
So like if I'm in the rural clinic and my provider says that I need an antibiotic, and it'll be filled out of here, for how many days would you get? Would you get
In
your
the
full
rural health
prescription?
clinic, they would just get a one-time dose because that is it's considered self-administering.
Okay.
So that's what Sarah does right now. We just have like a cupboard that we have it in, and we're doing it manually and tracking it manually. This will take that place, and we'll tell our staff when it needs to be filled and not, and when people are dispensing out of it. It's also a monitoring for the people that are getting into it. Like it's hard for us to monitor that when it's in a cupboard, and it's required by state and federal
So
law.
it gets dispensed through a computer system that's built
Right.
into the actual cabinet so that
Yeah.
it knows that this is the person that
Right.
requested the med, and
Yeah.
it delivers only the dosage that it's required, and then tracks all that just as it does when it's stocked. How much time do you think it'll take to get staff trained and transition?
I don't think too much. Honestly, many of them have already probably worked in an Omnicell in another unit. So, but it's pretty easy. We do Omnicell training every year for staff, so I orient the new nurses that come. So it's pretty not bad. The system is user-friendly, I would say. There's really not a lot to it. You go there, you put your finger on it, it shows the order that the doctor put in there, and it's going to connect you to that drug that is built in Epic. That actual drug that has that actual NDC, and then you're going to scan it out, and it's going to make sure. It also gives us a double scan because they scan at Omnicell and then they scan at bedside. So that's a dual scan before that patient actually gets that drug, which is a good check. Very good.
So is the refilling of the machine dual control too? I mean, for
Yes.
accuracy to put it
Yep,
in the
we have
right
to
slot
scan
or
it.
the right?
Yeah, we have to scan it in.
So it's all,
So it helps us
It's not-
too. So like when we're putting all those drugs in, Omnicell never used to have scanning in it, so that was a real deal for our staff, like stocking it. We really had to check all that, but now we can scan them in and make sure that we're getting them in the right slot.
In the right hours.
Yeah, so it's changed a lot.
So Omnicell has actually been providing your storage containers today, now that we've just transitioned to these.
To those areas,
to
correct,
the- okay.
yeah. So in the endoscopy suite, we do a lot of Diprovan, and that's a drug where they put them under, and it's not a narcotic, but it's a sought after drug. So like, we need to get that more in a controlled area, so that's why we're asking just to meet those guidelines, and that's why we're asking, one of the reasons why we're asking that, but we're also going to use that on the cell for the outside of the surgical department, so they don't have to go back into the ORs and pull drugs. They can just be out there in that open area when they're patients are out there and pull drugs from there. So it's gonna be a lot more convenient for those nurses in that area. Yeah.
And you say they're pretty robust, so you don't have to worry about any power failures and things like that interrupting the
We
system.
really haven't, I mean, I've been here 13 years, I really don't have one time that I've had a problem with it, knock on wood, though. And not be asked to do that, but really no. Really, they really do, they take a beating, honestly, because there's a lot of people in and out of them, so I've always really liked Omnicell. Our other option would be Pyxis. Pyxis holds a lot less drugs, and they just break a lot more often, so they're a good machine. They last a long time. I mean, our machines before, gosh, we had them for what, you guys have like 12, 15 years before we had to replace them, and really didn't have any problems with them. So you do get your money's worth out of them, I would say that.
This is, to be clear, this is like a mobile cart, or?
Well, it's stationary, and it has to be. It's just in that unit,
Okay.
and then it's kind of like a vending machine,
All right.
a big vending machine. I know that sounds weird, but that's kind of what it's like. And so it does take a lot of pressure off. I just really like to also take a lot of pressure off of the night house supervisor.
Is that kind of what it
Yes.
looks
Yep.
like? Okay.
Yeah.
So it's just looks like about a 6 foot tall cabinet with
Right.
a screen on it and multiple drawers. Yeah, okay.
It will complete our system. So now that we have remote verification, which is required since we're not a 24-hour pharmacy, which in the long run would be a lot more expensive to staff that 24 hours, so it's a cheaper route to go. But that remote verifying pharmacy can check the order, and then they can get it out of the Omnicell, which has been checked by another pharmacist before it goes in there and scanned in. I really would like to eliminate the house supervisor coming down and getting drugs, because they're not dispensers and it's a liability. So, so we're just kind of completing the package, what we already have, I guess is how I
I
put
have
it.
one more question.
Yeah,
Is it in
go
your capital purchase? I'll make a motion to approve the purchase of the Omnicell.
I will second that motion.
Okay, that was a yes, and then we have a first and a second. Without any questions, can I get a motion or a vote? All in favor? Yep.
Thank you.
Anybody opposed? All right.
Thank you, Nancy.
Motion
Thank
carried.
you.
Now we got Christie with the financial statements.
I know you guys are kind of pushed for time here, so I guess you've had.
Probably have a couple minutes,
Okay.
but
Well, you have the financial reports in the packet, and Ruth can send out these condensed ones. So it's just the preliminary audit, a preliminary financial report before we get to the audit, but we've had a pretty successful year. Our bottom line is net income from all sources of $6 million this year compared to $5 million last year. So we're up 16.2%. Majority of that is we've had some good investment returns, plus we're still in the Medicaid directed payment program. So I kind of wanted to touch on that since that's been brought up several times, so I can kind of run through that quickly. IHA had a webinar last week that they went through how they're interpreting those regulations and how that would affect us. So 3 parts of it affect healthcare, the big beautiful bill. So the provider tax reduction, that's really handled at the state level, but the bill is to require that reduction to 3.5%. Iowa's only at 1.9%, so they really have no effect on the Iowa directed payment program for that piece of it. The payment rate, historically, the directed payment programs approved by the CMS across all multiple states is to get us closer to getting paid at commercial rates. We are currently, this bill requires us to get by 2033 down to the Medicare fee schedule. Currently, we are at 168% in Iowa of the Medicare fee schedule. So beginning in state fiscal year of 29, so in September of 28, they'll start reducing that 10%. But as that happens, also Medicare rates increase every year. So there'll be a shrinking of that gap, so it won't actually be a full 68%. And Iowa is expected to have a $1.9 million decrease every year once that starts. IHA is working on getting individual facility estimates out after they continue to look at the reimbursement or the regulation side of it and interpreting them. So hopefully by the middle of September, we'll have our individual estimates from then, so we'll share that with you. The third part of that is the rural health transformation funding. So basically to mitigate some of those reductions, they put extra funding in there for rural health facilities. So it's $10 billion a year for a 5-year period. The state has to apply for that, put an application in. Once the state's approved, that application includes improving access, improving outcomes, use of technology, identifying causes of standalone rural hospitals, why we're at risk, and service reductions. So multiple different things in that plan. So 50% of those funds will go to the states that have approved plans, and that will be dispersed to the facilities. The other 50%, there'll be some sort of a, CMS has the discretion to use those funds as they see fit. So I'm assuming down the road then there will be some application process for that. So kind of currently at 10% of what we're getting is about $400,000 a year. So that's what we'd look at from a high level, but we'll look for IHA's estimates.
Would there be any likelihood that a state wouldn't apply for those funds?
No, and IHA said when we had our webinar that the state Health and Human Services is planning on putting together an application, yeah.
Okay.
They would definitely apply for those funds.
Okay.
So. Any questions?
So maybe not as bleak as initially thought, but still it's going to be a reduction over time.
Yeah. And you know, it's not really set to be until 2033 for sure, so who knows what our political outlook will look at that time too. There's a lot of room for change
Well, that was
there.
my question about the state level, if
Right.
it was politically driven or not, like if they, you know what I mean, that was whether or not they participated in a program or not. That was
Yeah,
what I was-
they'll participate in it, so.
And who knows what changes may be made to that as it goes on.
Yep, yep.
So the Medicare rate, you know, as you said, will shrink. Go ahead and approve them. I'll ask my question later. Go ahead.
Go ahead.
Well, I was just curious, like you said, that Medicare rate, you know, that gap will shrink as it goes higher. But won't the cost continue to go up on that
Oh, yeah.
Medicare? I mean, so
Yeah.
like it probably won't shrink a lot.
Inevitably, yeah.
It'll still
Yeah.
keep, the difference will still be there. Okay.
Yeah.
For sure.
Good point.
Approval of the June financial statement?
No, first and a second, all in favor?
Aye.
Opposed, same sign. Motion carries. If there wasn't any other comments or, did you have something?
When will your audit start?
The auditors will be out here mid-September, so they usually try and present everything at the October meeting.
Yep.
Good luck.
Always, they do good.
They do.
Okay, we'll go into closed session, probably with code 21.51, and can I get a motion for that?
I move we go into closed session.
Second.
In a second, we'll do roll call.
Terry Tornation, aye.
Zimmerman, aye.
Larson, aye.
Frederick, aye.
Cohorst, aye.
Beaker, aye.
All right. Approved, we'll go into closed session.